Hello and welcome. In this video, we are going to talk about the Green Top Guideline published in 2016 on endometrial hyperplasia by the Royal College of Obstetrics and Gynecology. Remember to follow the instructions and the information about the grades of recommendations and the meaning of good practice point. I have discussed this in detail in my earlier video. See reference in the description box below. Similarly, this is a reminder for the methodology for classification of evidence levels. Going back to the Green Top Guideline, we see that this guideline is the first edition for this topic. And this is a joint guideline between the Royal College of Obstetricians and Gynecologists and the British Society for Gynecological Endoscopy. So the World Health Organization classification of 2014 recommended the description of the classification as based on two groups. And this was without atypia and with atypia. And there is evidence level category D. As far as the risk factors for endometrial hyperplasia are concerned, these may vary in different countries, but generally speaking, these are considered as the risk factors. And so obesity and inactivity are two of the major risk factors associated with the development of endometrial cancer and endometrial hyperplasia. This involves dietary habits, exercise, and the use of hormonal therapy, which are all factors which are modifiable. Currently, diet and exercise programs are not integrated into standard treatment programs for patients with endometrial hyperplasia or endometrial cancer. Moving on to the guidelines, we find that there is evidence for diagnostic and surveillance methods. Endometrial surveillance should include endometrial sampling by outpatient endometrial biopsy, and this is graded as evidence level D. There is insufficient evidence evaluating CT scanning or MRI or biomarkers as an aid in the management of endometrial hyperplasia, and their use is not routinely recommended. And this is evidence level B. The guideline further describes the diagnostic and surveillance methods of endometrial hyperplasia. Diagnostic hysteroscopy should be considered to facilitate or obtain an endometrial sample, especially when outpatient sampling fails or is non-diagnostic. This is a good practice point. That means that it is recommended best practice based on the clinical experience of the guideline development group. The same group also advises that transvaginal ultrasound may have a role in diagnosing endometrial hyperplasia in pre- and post-menopausal women. This is not generalizable to all centers, but only in those centers where such correlation has been proved to occur. Direct visualization and biopsy of the uterine cavity using hysteroscopy should be undertaken where endometrial hyperplasia has been diagnosed within a polyp or other discrete focal lesions. Again, a good practice point. So here we try to understand that if a patient has an endometrial biopsy, irrespective of whether it is an outpatient biopsy or an inpatient biopsy, and the result of the histopathology report shows that there is endometrial hyperplasia without atypia, then what will be the initial management of that patient. So the guideline recommends that women should be informed that the risk of endometrial hyperplasia without atypia progressing to endometrial cancer is less than 5% over a 20-year period, and that the majority of cases of endometrial hyperplasia without atypia will regress spontaneously during follow-up. This is evidence level B, and this means a body of evidence including studies rated as 2++, directly applicable to the target population and demonstrating overall consistency of results. The guideline further recommends that observation alone with follow-up endometrial biopsies to ensure disease regression can be considered, especially when identifiable risk factors can be reversed. However, women should be informed that treatment with progestogens has a higher disease regression rate compared with observation alone. And the evidence for this is evidence level C. Following with the guideline, it says that reversible risk factors such as obesity and the use of hormone replacement therapy should be identified and addressed if possible. In other words, the patient should be put on a strict diet to make sure that she does not gain weight and, if possible, reduce some weight. And if she is on hormone replacement therapy, then this should be reviewed and stopped if necessary and if possible. Progestogen therapy is indicated in women who fail to regress following observation alone and in symptomatic women with abnormal uterus. If we just want to ask ourselves the question that how do we medically manage hyperplasia without atypia, the answer then is that both continuous oral progestogen treatment as well as local intrauterine progestogens are effective in achieving regression of endometrial hyperplasia if it is without atypia. And this is evidence level A. So evidence level A means the highest level of evidence which is based on high quality meta-analysis and systematic reviews of randomized controlled trials or randomized controlled trials with a very low risk of bias. Moving on, the recommendation also says that the intrauterine system of release of levonorgestrel should be the first line medical treatment because compared with oral progestogen, it has a higher disease regression rate with a more favorable bleeding profile, and it is associated with the fewer adverse effects. Now again, the recommendation says that this is evidence A, which means the highest possible evidence that can be available for making decisions. But remember that if you are living in a country where a patient cannot afford this method of treatment, or if it is unacceptable for her, then again, you always can fall back upon oral progestogen. Moving on, we see that further recommendations regarding medical treatment include continuous progestogens, and these can be either medroxyprogesterone 10 to 20 milligrams per day if it is available in the market, or norethistérone, which is Pramelot N, 10 to 15 milligrams per day for women who decline the intrauterine system for the release of levonorgestrel. The evidence for this is level B. So level B means that it is based on trials, but these may not be randomized controlled trials. Further recommendations include cyclical progestogens should not be used because they are less effective in reducing regression of endometrial hyperplasia without atypia compared with continuous oral progestogen or the intrauterine system. So basically what this recommendation is saying is that you should give them the oral progestogen continuously and not give them any breaks if you want to have complete regression of the endometrial hyperplasia without atypia. The question arises that if you start a patient on oral progestogen or on the intrauterine system for delivering progestogen, then what should be the duration of the treatment and how should you follow up these patients in those cases where the woman is presenting with hyperplasia without atypia? So recommendation is as follows. The treatment with oral progestogens or the intrauterine system should be for a minimum of 6 months in order to induce histological regression of endometrial hyperplasia without atypia. And this is level B evidence. If adverse effects are tolerable and fertility is not desired, then women should be encouraged to retain the intrauterine system for release of levonorgestrel for up to 5 years, as this reduces the risk of relapse, especially if it alleviates normal or abnormal uterine bleeding symptoms. Endometrial surveillance incorporating outpatient endometrial biopsy is recommended after a diagnosis of hyperplasia without atypia. So far, the level of evidence for this is level C. So what is the indication of surgical management for patients or women in whom there is endometrial hyperplasia without atypia? So hysterectomy is not a first level treatment or a first line treatment for hyperplasia without atypia because progestogen therapy induces histologic and symptomatic remission in the majority of women and avoids the morbidity associated with major surgery. Level of evidence is C. Hysterectomy is indicated in women who are not wanting to preserve their fertility when there is progression to atypical hyperplasia during the follow-up, or there is no histological regression of hyperplasia despite 12 months of treatment, or there is a relapse of endometrial hyperplasia after completing progesterone treatment, or there is persistence of bleeding symptoms, or the woman declines to undergo endometrial surveillance or comply with medical treatment, and all these are evidence C. This means that the patient should be on follow-up in terms of monitoring the type of changes that are taking place in the endometrial lining. And if these changes are not positive, or if they are undergoing a change towards atypia, then that means that now the patient should be considered for hysterectomy. This is also true for patients who have persistence of bleeding symptoms, or if the patient does not want to have any endometrial surveillance or comply with medical treatment. Moving on further with the same principle of indication of surgical management for women with endometrial hyperplasia without atypia, we find that if the women are postmenopausal and if they require surgical management for endometrial hyperplasia without atypia, then this should be offered to them with a bilateral saprophorectomy and total abdominal hysterectomy. This is a good practice point, which means that it is a recommendation based on the clinical experience of the guideline development group. For premenopausal women, the decision to remove the ovaries should be individualized, depending upon risk factors. However, bilateral salpingo-oophorectomy should be considered, as this may reduce the risk of future ovarian malignancy. So this is a low level of evidence, evidence level D, which means extrapolated evidence from studies and therefore not very good evidence in terms of its robustness. If you do surgical treatment, then a laparoscopic approach to total hysterectomy is preferable as compared to an abdominal approach, as it is associated with a shorter hospital stay, less post-operative pain, and quicker recovery. And this is evidence level B in women who have endometrial hyperplasia without atypia. For these women, endometrial ablation is not recommended for the treatment because complete and persistent endometrial destruction cannot be ensured, as it is a blind procedure. And intrauterine adhesion formation subsequent to the endometrial ablation may stop a proper endometrial histological surveillance or may be detrimental for endometrial histological surveillance. And therefore, it is not recommended as a follow-up treatment surgical plan for women without atypia. When we discuss the initial management of patients of those women who have hyperplasia with atypia, then there is a different set of recommendations. So the initial management of atypical hyperplasia is that you do a total abdominal hysterectomy because the risk of underlying malignancy or progression to cancer, and the level of evidence is B. A laparoscopic approach to total hysterectomy is preferable to an abdominal approach, as it is associated with shorter hospital stay, less post-operative pain, and quicker recovery. And there is no benefit from intraoperative frozen section analysis of the endometrium or routine lymphadenectomy. Moving on further about the initial management of atypical hyperplasia. Whenever we say atypical hyperplasia, we mean that hyperplasia with atypia. So in these patients, you should preferably do a bilateral salpingo-oophorectomy with the total hysterectomy. And in cases of premenopausal women, the decision to remove the ovaries should be individualized. However, bilateral salpingectomy should be considered, as this may reduce the risk of future ovarian malignancy. And endometrial ablation is not recommended because complete and persistent endometrial destruction cannot be ensured, and intrauterine adhesion formation may preclude endometrial histological surveillance. You may come across a situation where a woman has endometrial hyperplasia with atypia, and if she's offered surgery, she says that she does not wish to have surgery, or the patient may have a lot of comorbidities and may not be suitable for surgery. In such a situation, what is the recommendation by the guideline group? So here we have 3 recommendations which are based on a best practice of the clinical experience of the guideline development group. Women who wish to retain their fertility should be counseled about the risk of underlying malignancy and subsequent progression to endometrial cancer. Pre-treatment investigations should aim to rule out invasive endometrial cancer or coexisting ovarian cancer. This means endometrial biopsy coupled with MRI and CT findings. Histology, imaging, and tumor marker results should be reviewed in a multidisciplinary meeting and a plan for management and ongoing endometrial surveillance formulated. So this set of recommendations does not have evidence beyond the recommendation of the group that made the guidelines. What if a woman has endometrial hyperplasia with atypia and she does not want to have surgery or is unsuitable for surgery? So what medication can we give her? First-line treatment with the intrauterine system for release of levonorgestrel should be recommended with oral progestogens as a second best alternative. And once fertility is no longer required, hysterectomy should be offered in view of the high risk of disease relapse. So what is the recommendation in a patient who has atypical hyperplasia and who has not had a hysterectomy? In such cases, we will do routine endometrial surveillance, which includes endometrial biopsy. The schedule at which the biopsy will be done will be individualized and be responsive to changes in a woman's clinical condition. So you have to do a review interval should be every 3 months. A biopsy is taken until 2 consecutive negative biopsies are obtained. By negative biopsy, we mean that a normal endometrium, and this is level of evidence B. So supposing the patient does not have any symptoms like irregular vaginal bleeding, and suppose that she's having her endometrial biopsies every 3 months, then if she has 2 negative endometrial biopsies, then long-term follow-up with endometrial biopsy of every 6 months to 12 months is recommended until a hysterectomy is performed. So this is only in those cases when a woman is asymptomatic, that means she does not have any irregular vaginal bleeding. And secondly, her biopsy is negative for any abnormality. In such cases, you still have to continue to do endometrial biopsies every 6 months to every 12 months until a hysterectomy is performed. In a situation where endometrial hyperplasia has been diagnosed and the patient does not wish to have a hysterectomy and she's put on some kind of progestogen therapy continuously and she wants to conceive, then what are the recommendations by the guideline group? The group recommends that disease regression should be achieved on at least one endometrial sample before women attempt to conceive. Women with endometrial hyperplasia who wish to conceive should be referred to a fertility specialist to discuss the options for attempting conception, for further assessment and for appropriate treatment. So there is not a lot of evidence for this, and whatever evidence we have is evidence level D, which is based on case reports or from case studies. Assisted reproduction may be considered as the live birth rate is higher and it may prevent relapse compared to women who attempt natural conception. And prior to assisted reproduction, regression of endometrial hyperplasia should be achieved as this is associated with a higher implantation rate and clinical pregnancy rates. Systemic estrogen-only hormone replacement therapy should not be used in a woman with a uterus. All women taking HRT should be encouraged to report any scheduled or unscheduled vaginal bleeding promptly. Women with endometrial hyperplasia taking sequential HRT preparation who wish to continue HRT should be advised to change to continuous progestogen intake or use the intrauterine system of release of levonorgestrel or continuous combined HRT preparation. Women with endometrial hyperplasia taking continuous combined preparation should have their need to continue HRT reviewed and reevaluated. Discuss the limitations of the available evidence regarding the optimal progestogen regimen in this context, and consider using the intrauterine system for release of levonorgestrel. Subsequent management for follow-up should be as described in the preceding sections of the guideline. So what we learn from this is that if a woman has a uterus and she has endometrial hyperplasia, and if she wants or she needs hormone replacement therapy, then it can be given, but in very strict situations and with strict surveillance. Another situation is women who have breast cancer and they are on adjuvant treatment with tamoxifen. And if they develop endometrial hyperplasia, then how do you manage? And how do you counsel patients who are on tamoxifen? So women taking tamoxifen should be informed about the increased risk of developing endometrial hyperplasia and cancer, and they should be encouraged to report any abnormal vaginal bleeding or discharge promptly, as these medications are considered to have an increased risk of hyperplasia as well as of cancer. So in such patients, should they be given prophylactic progestogen if they are already on tamoxifen? It has been seen, and this is level of evidence A, that if the woman has an intrauterine system for release of levonorgestrel in place and she's taking tamoxifen, then this will prevent polyp formation and reduce the incidence of endometrial hyperplasia. So we don't know whether this has any beneficial effect on breast cancer, but definitely it does have a beneficial effect on the lining of the uterus. So in case the woman develops endometrial hyperplasia, then this is a decision for the breast surgeon, the oncologist, whether she should continue taking tamoxifen or whether she should stop taking tamoxifen. Supposing that there is endometrial hyperplasia which is confined to an endometrial polyp, then how should it be managed? This is not a case of tamoxifen therapy, but an individual case of endometrial polyp. So the endometrial polyp should be removed, and with the histopathology to confirm the diagnosis. And at the same time, the patient should then go on the follow-up pattern and schedule as for endometrial hyperplasia. With this, we come to the end of the video. If you like the video, then please press the like button, subscribe, comment, share, and press the bell icon for notification of further videos. Thank you and goodbye.